Hello, everyone. I'm so excited to welcome you into Free Webinar Wednesday with Archer Review. We're going to be getting started in just 1 minute. This is my favorite free webinar of all time. Congenital heart defects, man, you guys might not love them yet. I'm hoping maybe by the end of this little session that you will. They are one of my favorite things of all time to talk about. And it didn't used to always be that way. Like, in nursing school, they were hard. I definitely don't feel like I got a good comprehensive education on that. And it was super, super challenging to apply when I got to work. And one of the first places that I worked was in a pediatric cardiac ICU. So we had lots of babies with heart defects, and I got to start really understanding what was going on in these defects. And once I could kind of figure out how the blood was flowing and all that sort of stuff, they started to make a lot more sense. And I fell in love with caring for these little patients. So I'm really, really excited to just dive into it with you guys today. Let's go ahead and jump in. We are going to be using Slido so that I can talk to you guys, right? I want to know where you're joining from. I want to know a little bit about you. So whether you are here with me on Zoom, on our YouTube channel, Facebook page, or even Instagram, go ahead and either scan that QR code that you see. You can take your little phone and pull up any camera app, just scan it, or go to slido.com if you're on your computer or something. Type in that little number right there and you'll join our class. All throughout class, I'm going to be able to ask you questions. You're going to be able to ask me questions. I want this to be a fun interactive session, right? Like, no need to make this super formal. So just let me know where you're joining from today so I know who I'm talking to. We've got people all over from Maryland, New York. I'm streaming to you from North Carolina. That is home for me. It is a yucky, rainy day outside, so I'm happy to be doing this instead. Chicago, San Diego, I bet you have much nicer weather going on in San Diego. Hopefully, at least, fingers crossed for you. Some people from Facebook saying they're joining in from Canada or from the Philippines. So we've got big time differences, people from all over the world. Hopefully, all of you, though, are pretty excited to jump into heart defects. Here's kind of what you can expect over the next hour or so. We're going to dive into a lot of this content together, and we're going to use that Slido so that you can check your knowledge, make sure you're understanding, and ask me lots of questions, okay? Now, make sure that you keep your phone or computer or whatever out and on that Slido, because as you answer the questions and the faster you answer them, you are going to get points, and the winner by the end of the night is going to get 2 free private tutoring sessions. That's valued at $75. You're going to get 1 to keep for yourself and 1 to give away to your best nursing pal. There's no friend like a nurse friend, so make your friend really happy and win that private tutoring session for them, okay? If everybody's got their phones out and ready to rock, we will jump on into our content. And really, where peds cardiac starts is how the heart develops, the actual development of the cardiovascular system, okay? Because when a baby is forming, when we have a fetus, circulation is a little bit different. It doesn't flow from the heart to the lungs, get oxygen, and go out to the body. And that's because a fetus is getting all of its oxygen already from mom. So it's kind of a waste of time to send that blood through the lungs. We call that pulmonary circulation. We just don't need to do that, right? So instead, the fetus has 2 holes in its heart that help that blood skip the lungs and just go to the rest of the body. They just bypass the lungs. They don't need to do that. The first of those holes, it's called the foramen ovale. It's literally just a little opening between the right and the left atrium. The second hole is just between what I call the two great vessels. That's the pulmonary artery, bringing blood from the right atrium out to the lungs. And that's the aorta, of course, bringing lungs from the left ventricle out to the body. So between those two great vessels, there is a little hole that's allowing that blood to move through that hole. Now, whenever we have blood that moves through a hole, it's called shunting. So my very first Slido question for you guys, okay? Everybody go ahead and get your phones out, get ready so you can enter that contest. My very first question is that foramen ovale, where does it allow blood to shunt? Where do we have shunting of blood from that foramen ovale? Look at your options. Answer for me. The faster you answer, the more points you get. All right, answers in. Are we ready? Okay. Awesome, awesome job. When we have blood shunting through the foramen ovale, it is going between the atria. The other hole is that ductus arteriosus, and that is when the blood is moving from the pulmonary artery to the aorta. You got it. Okay. So now when we get into the different cardiac defects, a lot of them are going to have to do with those two holes that we had forming in fetal circulation. When I say we have a cardiac defect, I'm talking about an abnormality in the structure of the heart itself, okay? So maybe one of those holes didn't close. Maybe there's a hole somewhere else where there shouldn't be. Maybe something is too big or too small. We've got a lot of terminology to talk about. If you know these words, you're going to have a much, much, much easier time understanding all these different defects that we are about to talk about. The first one is stenosis. Something gets stiff. Think S for stenosis, F for stiff. If a valve or a part of the heart gets too stiff, it is stenosed. The second term is atresia. That something doesn't develop. For example, mitral valve atresia. The mitral valve, it really didn't develop. It's underformed. Another word for underdeveloped is hypoplasia. So let's say one side of the ventricle doesn't fully develop. It's hypoplastic. And if it develops too much, it gets big, really muscular. That is hyperplasia. So hypo, not developed, hyper, more developed than it should be. Now, another word for narrowing is a coarctation. And this is specifically when we have some sort of stricture narrowing a blood vessel, okay? So again, we're going to continue to go over these throughout the night as we talk about specific defects. But I promise if you learn the terms, it's really going to pay off. A lot of them will make sense much faster. Now, when we have some of these defects, blood starts to do funny things, as you're going to see. One thing that can happen is our deoxygenated blood can mix with our oxygenated blood. And you'll hear purple blood is kind of what people will say. It's purple blood. And this is when we get a mixing of those two bloods. Sometimes if a child has this defect, we'll call them a mixer because they're mixing those two types of blood together. Some children will be dependent on that ductus arteriosus that we just talked about in order to get any blood going out to their body. So in that case, if we talk about a child who needs their ductus to be open, we'll call them ductal dependent. And lastly, coming back to it again, because I think it's one of the most important, is that shunting. Once again, shunting is when that blood moves from one area to another, especially across one of those holes. So clearly, if the blood is shunting, it can go in either direction. And when we're talking about directions in the heart, we're really talking about from the left side to the right side, or the right side to the left side. And which way is that blood going? This might sound kind of nitty-gritty or not important, but this is the crux of why you're going to have the symptoms that you do in your different defects. So what you need to remember is two key concepts. Number one, blood on the right side is deoxygenated. It just came back from the body. It doesn't have any more oxygen. It's that blue blood. Blood on the left side of your body, however, that's your red blood, your oxygenated blood that just came back from the lungs. Amazing. Now, we need to think about which direction the blood's going to move. And blood is lazy, okay? It always moves from areas of high pressure to low pressure, okay? It's not going to go walking up a hill if it's got a downhill path that it can take, just like me. I'm not going to do that. Now, which side of the heart has more pressure? Tell me down in your comments. Is it the left side of the heart? Is that the high pressure side? Or is it the right side of the heart? Tell me what you guys think. The left side. Tanisha says left. Lincel says left. Yeah. Christine also commenting saying left. Okay, I agree. The left side of the heart is bigger. It's more muscular. It is built to pump blood out to the body, which is way bigger than the right side just pumping blood to the lungs. So the left side has more pressure, and blood is naturally going from high to low pressure, okay? So in a healthy, normal pressure situation, if we have got a hole and blood is going to shunt, that's what we're talking about, this shunting, it's going to go left to right. Now that's good. If I'm going to have a shunt, if my heart has to have a hole in it and it has to be shunting, that's what I want. Because remember key concept number one, your blood on the left side has oxygen. If it shunts from left to right, I get more oxygenated blood going out to my lungs. I'm not having any cyanosis. I'm just getting a lot of extra blood going to my lungs. So that's when we could have some heart failure signs and symptoms. The lungs are going to get really congested with the extra blood coming from left side shunting to right side. But your baby's not going to be blue. They're not going to be cyanotic because they're not getting deoxygenated blood out to their body. Naturally, you can see if something changes and we get blood moving from the right side over to the left side, then we get that blue deoxygenated blood out going to the aorta to the body. And that's when the baby turns blue. That's when you're cyanotic. So I know that was a whole lot of nitty-gritty, but it helps you understand the reason behind these different types of heart defects. In your cyanotic heart defects, you have a right to left shunt. Blue deoxygenated blood, it's going out to the body. Baby's turning blue. That is not a good problem. In your acyanotic defects, you have a left to right shunt. So perfect. It's not good that they have this hole in their heart, but the blood's moving from left to right, and it's nice oxygenated blood that's getting out to the body, okay? So we're going to talk about all these defects up on the screen, break it down, and hopefully you're going to kind of start to get an understanding of what's going on, right? So get ready. I've got one question for you here, guys, and we're going to check in and see who is on the leaderboard to win that private tutoring session. I want you all to tell me, of these terms coming up on the screen, which indicates a stiffening or thickening, okay? Which of these indicates a stiffening or thickening? You got to know all these terms for your heart defects. What do we think? Okay, here we go. All right, smart cookies. 93% of you got it. Absolutely, it's stenosis. When we have a stenotic valve, it is thick, it is stiffened. Good, remember that. Okay, let's see who's on our leaderboard. Who's number one? So far, Liz. All right. But Aaron, you're close in second by just 1 second. Okay. So anybody's game. We've got 10 questions to get through tonight to see who that winner is. Nice work. Okay. Now, before we get into every type of defect, I want to go ahead and put this resource up here for you guys in case you need it. Tell me down in the comments so I know who's here today, who already is an Archer Review subscriber and who is just coming here to check things out maybe for the first time today. That way I'll kind of know what you guys might need from me, what questions you might have, and all that jazz. Okay. Archer subscriber, a couple of you guys from Facebook, you've already got the packages. Really cool. Okay, so you guys have some of these resources. Rose is here for the first time. Okay, good to know. So if you are a subscriber already, you know about the SurePass program. This is going to be our most recommended package. Hopefully a lot of you already have it. It has everything. It's got your QBank, almost 3,000 questions, lots of NGN stuff. It's got your on-demand videos. So if after you go through tonight's live webinar, you're like, oh, that was good info on heart defects, but I did not remember it all. SOS. We've got the live video saved for you. You can watch it on demand as much as you need. Additionally, you're going to get access to a whole lot of live interaction. Every single day we do a live lecture. And then every month we offer the comprehensive 3-day live review where we go over all your high yield concepts, boom, 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 in a big 3-day shebang. It's really, really fun. So you get the chance to join that one time. It's offered every single month. So most people will do that 3-day live like a little bit before they take their NCLEX for a final study, wrap up, make sure they're really, really ready, right? Okay. So hopefully that's what my friends joining who already have Archer Review have. If you are new here, I'm seeing a few people on Instagram that are new. I'm so glad that you're here. Nice, welcome. You know, go ahead and scan that QR code, or, you know, if you're on your phone on Instagram, you can't do that. So just go over to archerreview.com and it'll be the first little bubble at the top. You click on nursing. And this is really what I recommend you guys check out. If you like the lecture today and you need more, if you've got questions about it, you know, pop them down in the comments. We've got nurses on who are going to make sure that they chat with you, help you out. I mean, I'll personally DM you after if you've got anything outstanding. So that's my recommendation. Enough of a little brain break there. Let's dive into why we're all here and really look at these specific cardiac defects, okay? Now, I want to make it as simple as possible, so we're going to go by category, kind of lump them together. The first category is your acyanotic. So tell me in the comments, which direction is the blood going to be shunting in an acyanotic defect? Is it going to be going from right to left or from left to right? What do we think? Yes, Lincel, you got it, 100%. You know what you're talking about. That's right. That's right. Fabian on Facebook, you know it. That's 100% correct. If it's acyanotic, we know that it's going from left to right. Now, we've got a hole in the heart. Red oxygenated blood goes from left to right. It goes back to the lungs. So we get some extra blood to the lungs. It can cause some heart failure signs, but the baby doesn't turn blue. That is your key takeaway. Nice job. You guys are understanding it. So here's the first way that can happen. I'm sure you've heard of this. It's your PDA, your patent ductus arteriosus. So we, during fetal development, have that hole between the aorta and the pulmonary artery. Let me kind of highlight that here for you. It's right here. That's what's allowing us to kind of skip the lungs, but that should close after birth, okay? Let me be clear. It's great we have that hole for the baby, but once they're born, that hole needs to close. It should close 12 to 72 hours after birth. If it doesn't, if it stays open, that's when we have our patent ductus arteriosus. Now, in addition to everything we've talked about, there's one key finding that I want to make sure that you guys remember. I've got it in red here. It's a machine-like murmur. Machine-like murmur is hands down the characteristic finding of a PDA that the NCLEX is likely to test you on. It's kind of like a little buzzword, so make sure you remember that. What do we do about a PDA? Depends on how big it is. If it's really small, a lot of times it just closes on its own, no biggie. If we need to help it along, premature babies in the NICU can be given indomethacin or ibuprofen. Either of those medicines, those will help close the ductus arteriosus. Now, I'm going to throw a little bit of a wrench here and challenge you guys. If we want the ductus arteriosus to stay open, we have another med. We have alprostadil. You've probably heard it called prostaglandins before, or even maybe PGE. Those are all the same thing, all the same med, okay? We give that to keep the ductus arteriosus open. Why would we do that? We're talking about this heart defect where this hole stays open. Wouldn't we want to close it? Why do you guys think we would have this medication that keeps it open? We're going to circle back to it. We're going to circle back to it. For right now, tuck it in your memory. Opening the PDA, alprostadil. It keeps it open. If we want to close it, we use indomethacin or ibuprofen. Okay? We're going to come back to alprostadil later. Now, let's look at another acyanotic defect since we're grouping them together. This one is a hole between the two atria. It's called an atrial septal defect. Super straightforward, right? Again, we've got red oxygenated blood. It goes across that ASD from left to right. Extra blood to the lungs, so we can have some heart failure signs and symptoms. But all good red oxygenated blood going out to the body. So we are not having any cyanosis. Okay, what do we do about an ASD? Well, once again, if it's really small, it's very possible it can just close by itself, and we don't need to do too much. But a big ASD, it will likely need a surgery to close it. Same thing if that hole is lower down in the ventricles, okay? So ASD, hole between the atria, VSD, hole between the ventricles. That one is typically a little bit bigger, so it's more likely to need surgery to close it, and you're more likely to see those heart failure signs and symptoms starting a little bit earlier in life. Because, I mean, we got a big hole between the ventricles, we've got a lot of blood shunting left to right and going to those lungs. So they might not be eating well, not gaining weight very well. And when you auscultate heart sounds, you're likely to hear a loud murmur from that blood whooshing across the VSD from left to right. The very last one I have for you is when we kind of combine the last two defects that we talked about. When we have both an ASD and a VSD, it's called an atrioventricular canal. Basically, the heart is kind of just one big chamber going on, right? Because we have one big atria, a single AV valve, and one big ventricle. So this is a much more serious heart defect. This isn't going to close on its own. That would be impossible. They are going to need surgery, and they're at even higher risk for heart failure because of so much blood shunting from left to right and going to their lungs. Okay, so let's recap the first four that they learned. And remember, these are your acyanotic defects. So first, you learned about the PDA. It's that opening between the pulmonary artery and the aorta. Then you learned the ASD, opening between the two atria. Then you learned the VSD, opening between the two ventricles. And lastly, kind of combining those two, you learned your AV canal, where we've got a single atria, a single ventricle, super high risk for heart failure. And we know they're going to need a surgery to fix that. But they're not getting any blue blood out to the body. So their baby comes out nice and pink, and we know it is acyanotic. Okay. Super good job learning that first group, okay? I'm going to quiz you now. Think back to your meds. Let's pull up our Slido. Everybody get ready and tell me what medication can be used to keep the PDA open. We had two different medications. Which one of them can keep the PDA open? Good. That's absolutely right, you guys. It's alprostadil. That is also called prostaglandins or PGE, okay? So remember, we're gonna circle back to why we might want to do that. Alprostadil keeps the PDA open. Now, acetaminophen, that was kind of a distractor answer, nothing to do with that. Ibuprofen and indomethacin, though, they both close the PDA. So that's like super common in the NICU. We've got a preemie, their ductus arteriosus stays open, and we give them some indomethacin or some ibuprofen to help close it. That's honestly much, much, much more common, especially if any of you guys are going to work in the NICU. I'm sure you're going to see that. Let's check in on our leaderboard. Who do we have? Liz hanging on to the #1 spot by just a couple seconds. All right. Remember, we still got quite a few questions to go, and that winner takes away 2 private tutoring sessions. So let's look at another question. What type of murmur are you going to hear with this PDA that we keep talking about? There's a very specific finding. You guys have to make sure you know it. All right. Yes, you've got it. It's that machine-like murmur. That's a buzzword for PDA. Totally tells you what you're talking about. It's kind of this constant whooshing. You hear it all throughout systole, and it sounds like a machine, okay? These other terms, these are descriptors for murmur. We grade our murmurs on a scale of 1 to 6 based on how intense they are. And we can describe the timing of the murmur based on if it happens in systole, S1, or diastole, S2. But none of those are consistent with a PDA. With a PDA, we hear our machine-like murmur. Really good. I love it. Oh, and Liz, you're really hanging on to the #1 spot. I like it, but we're only halfway through. So halfway through our little session tonight, quick brain break. I'm going to introduce you to one other product that you might like to hear about with Archer Review, since a lot of you, especially from the Instagram audience, said that you were new here. I talked to you a little bit about the SurePass program, where you got the QBank, the on-demand videos, and access to the live lectures. But what if you've tried the NCLEX before and you need an extra boost? You actually want tutoring sessions every week where somebody's going to keep you accountable and keep you on track. If that is you, then you need to look into our intense prep program. This is a 6-week, all-inclusive kind of classroom-like session that really gives you the extra oomph to get across the finish line, especially if you've tried on the NCLEX before. The reason that I say it's really helpful is that an instructor actually meets with you in a small group twice a week to review key concepts like testing strategies, prioritization, NGN questions. And then every week, they look at how you're doing. They look at your scores, your feedback, and address that with you so that you specifically can improve every single week. So not only is it going to keep you accountable because you're going to be like, all right, My instructor, Diane, is looking at my scores tomorrow. I better go do my assignments. Your assignments are actually going to be more meaningful because an NCLEX expert's going to go through them and tell you what you need to do. Instead of just like studying for kicks and giggles, you're going to study smarter, not harder, right? So this is a really great program if you are ready to buckle down, get things done, and make this next attempt your last attempt, okay? So again, you can scan your QR code. If you're on your phone, you can't do that, but you want to like get a little more info, just go to that archerreview.com. You'll be able to click through the menu items at the top, okay? And if you've got questions about these programs, I know a lot of you on Instagram said you're new, just comment, heck, send us a DM and I'll have a conversation with you personally when we're done here tonight. I can chat you back, okay? We're really open to questions, so let us know what you're thinking. Okay. Enough of a little brain break. We're halfway through and we still have quite a few defects to cover. The next group that we're going to look at all together is our cyanotic heart defects. Obviously, this is the opposite of what we just did. We looked at the acyanotic. They didn't cause that baby to turn blue. Now we're looking at that baby turning blue. We'll start off here with tetralogy of Fallot, one of the most important defects for you to learn. Tet means 4. So in tetralogy, we have a combination of 4 different defects. The first is one that you've already learned. It's the VSD. It's where we have this big hole in between the 2 ventricles. Next, we have pulmonary stenosis. Remember, stenosis is when something becomes thick and stiffened. So that pulmonary valve leading from the right ventricle to the lungs, it's big, it's stiff, it's thickened, yeah? Now, that makes it really hard for the right ventricle to actually pump blood out to the lungs. And just like any other muscle, when we work it out, it gets bigger. So our right ventricle hypertrophies, and it's bigger than it should be. Our last defect is called an overriding aorta. We see that right here. Normally, the aorta is just sitting on the left ventricle, bringing good oxygenated blood out to the body. But an overriding aorta overrides the right and left ventricle. It just sits on top of that VSD, which means it can pick up blood from either side. Now, this could be a problem, especially if we start getting more of that blue blood picked up by the aorta. Then it's going to send deoxygenated blood out to the body. Oh my gosh, our baby's going to turn blue. But remember, you guys, blood is lazy. It's only moving from areas of high to low pressure. And this left side is usually higher pressure. But that can change really quickly in tetralogy of Fallot. Because you see, what if the baby starts to scream and cry? That's going to really increase the pressure in their lungs. And it's going to put more pressure on that right side of the heart since that's hooked up to the lungs. So if that pressure gets high, all of a sudden, I'm not going to be shunting from left to right anymore. I'm going to start to have a right to left shunt. And that blue deoxygenated blood right over here, it's going to be shunting across the VSD, picked up by that overriding aorta, and now my baby's turning blue. This is what we call a Tet spell. Baby cries, blue blood goes out to body, and they are really cyanotic. It starts out in their lips, they turn a little blue, their face. The next thing you know, their whole body. They can have an SpO2 in the 20s to 30s because of all that blue blood the aorta is picking up. What do we do about it? This is what the NCLEX is going to ask you. Tet spell interventions. This is super important. We need to stop that right to left shunt. That's why the baby's turning blue. And what is causing the right to left shunt? The fact that that pressure on the right side of their heart is really high. And their really high pressure is because they're screaming and crying. I mean, that's what babies do. That's the only way they can talk, right? but we need to calm them down. Really, as soon as possible, we need to calm them down because then the pressure on the left side will be higher and we'll stop having that right to left shunt. They'll stop turning blue. That's why always your priority in a TET spell is to comfort and calm. I know you guys are right now yelling at me, Morgan, the baby's blue, give him oxygen. And I get that. But does oxygen fix the root cause of the problem? No, it's just treating the symptom. The root cause is that we have a screaming baby that's causing high pressure on the right side and pushing that blue blood out to their body. Calm them down and they will turn pink again. It's crazy. It happens really, really fast, actually. It's wild to see. So that's why your priority nursing intervention is comfort and calm. After you calm them down or while you're calming them down, yes, they're blue, give them some oxygen. We also can calm them down using some sedation. Morphine is always the drug of choice in a TET spell. That is a common NCLEX pharma question. Morphine is the drug of choice in a TET spell. We can also do a couple of things to help increase the pressure in their systemic circulation. So over on that left side to push against the right to left shunt. So that's things like putting them in a knees to chest position, like you see right here, just pull their little knees up, or giving them some IV fluid, like a little 10 per kilo bolus of normal saline. That volume increases their blood pressure, pushes against that right to left shunt. Those are all going to be later interventions. They're not your priority, right? First and foremost, comfort and calm. Now, that doesn't fix the baby's heart, right? That's not going to fix their VSD or their overriding aorta. That's just the acute treatment while they're having a TET spell. Overall, it's no secret this baby needs surgery. So usually they go home and grow maybe about 6 months, come back when they're a little bigger, and they get their TET repair, okay? And then their heart is repaired, they go on, they live full, long, happy lives. They'll need to be followed up by cardiac, but we can get a normal flow of blood going through their heart so that they can develop properly. Now, our next cyanotic defect is called tricuspid atresia. This is a bad one. When I see this pop up, I get really nervous. Remember what atresia means. It means that something doesn't develop. Obviously, right now, we're talking about the tricuspid valve. So remember, the tricuspid valve should be between the right atria and the right ventricle. If it doesn't develop, and we just have this wall right here, blood is not going to be able to flow through the right ventricle and out to the lungs. Instead, it's just going to skip the whole right side because there's no pathway for it. It's like the road is closed. So it takes a detour. It detours right over to the left side. It can do a little bit of mixing, but mostly that blue blood just goes out to the body. So this baby comes out very, very blue since there's no way for the blood to get over to the lungs. Clearly, we need to do something very fast to keep this baby alive. And this is where I'm going to ask you to think back to that alprostadil medication. Okay, remind me. What does alprostadil do? Can anybody answer in the chat for me and tell me what alprostadil does? Open, keep the heart open. Yeah, there we go. It keeps the ductus arteriosus open. Remember, that's that little hole between the pulmonary artery and the aorta. And alprostadil keeps it open. So it's kind of like a little escape hatch. That blood needs to get out to the body. And keeping that little opening, that escape hatch open, is going to save this baby. Honestly, it's going to just allow us time to plan for surgery. Because as you can see, looking at the heart, this baby, again, needs surgery so that we can get the blood flowing in the right way. Okay, I want to quiz you a little bit. Get ready to have that Slido back open, okay? And I'm going to quiz you about the Tet spells because that is what you're very likely to see. I want to know what medication is considered the drug of choice for a Tet spell because I think a lot of you could see this on your NCLEX. Get ready here. Which of these meds is your drug of choice? They're having a Tet spell. What are you grabbing? Okay, let's see what we got. Boom, 94% of you are absolutely right. Morphine, grab that morphine, okay? It helps kind of like relax the heart muscle, get the blood flowing correctly. Mostly, it calms that baby down, okay? Liz, hanging on to your lead. I like it. We're halfway through with our questions, but I've got another one for you. Another Tet spell question. I know morphine's the drug of choice, but what's your priority intervention? You going to give that morphine or are you going to do something else first? Good. 80% of you know that the root cause of that Tet spell is the screaming and crying. Your priority is to calm them down. Liz, you are on fire. Oh, man. Okay, you guys, last quick little brain break here before we wrap up our night. For those of you who are new here, Archer Review offers the best of the best private tutoring. So I know I've told you about all of our packages that include this, that, and the other, but if you really just need a single session, you just need somebody to sit down with you and tell you what's what, sort through your life, help you make a study plan, help you narrow in on those areas that you really need assistance with. Private tutoring is the absolute best option, okay? These are all NCLEX coaches that have broken down the test plan, studied what the NCLEX is all about, and excel in helping students get across that finish line. Every minute that you spend with them is going to be totally customized to you, right? That's the benefit of a private session. Yes, it's a little more expensive. It's $75 for your one session, but that session is going to give you so much bang for your buck because it is all about you. No one else is there, no distractions. We are just getting you to pass, okay? Now, we have more tutors that are just the ones on the screen, but these guys have tons of offerings. So you're going to see they're open every day. We have evening sessions. Allie is really consistently offering sessions at night. So if you've got kids, work, school, and you just need to study after all of that junk is over with, Allie is your girl, okay? Again, you can scan our QR code. You can just go to archerreview.com, or you can DM us, comment, let us know what you need help with. We will get you set up with the right tutor. Honestly, we just want you guys to pass the NCLEX. So we're going to do what we have to do, okay? All right, that was our last little brain break for the night. We don't have too much longer left, but we have another group of defects to talk about. And this is going to kind of put it together. We talked about our acyanotic, no blue baby. Then we talked about our blue babies, right? Tetralogy of Fallot and tricuspid atresia. So these next defects are where they're going to kind of mix together and where babies are going to be dependent on that ductus arteriosus staying open to get some blood out to the body. The first one is called transposition of the great arteries. Remember, the great arteries are the pulmonary artery and the aorta. They're going to get swapped, which is a really big deal. If the pulmonary artery swaps and hooks up to the left atria, and the aorta swaps and hooks up to the right ventricle, then they're going to send the wrong types of blood out to the body. We're going to get red oxygenated blood just circulating from the lungs back to the left side. and we're going to get blue deoxygenated blood just circulating back to the right side. A lot of people describe this as like two parallel circuits, right side, left side to left side. So we're not getting any oxygenated blood out to the body, and they will become cyanotic within an hour of being born if we don't start that alprostadil to keep the ductus arteriosus open, okay? And then, of course, no surprise, they're going to go to surgery. And our cardiovascular surgeons that are like very fancy plumbers, they're going to unplug that aorta from the right side, plug it back into the left, and same thing over for the pulmonary artery. Unplug it from the right or from the left and put it back where it's supposed to be on the right, okay? Really, really interesting surgery to see. Luckily has really good outcomes because it's a pretty simple concept or switch, right? We get it all hooked up correctly and they're good to go. The key I want you guys taking away is this alprostadil. We have to give that right away so that they can get some oxygen out to their body. That's going to be the same priority for our next mixed defect, which is called hypoplastic left heart syndrome. This is where the left side of the heart, left heart syndrome, no surprise, it's hypoplastic. Remember, that means it's underdeveloped. So all those structures on the left side of the heart here, they just do not form normally. Aorta, it's small, it's floppy. Atria, ventricle on the left side, they are small and underdeveloped. So when this ductus arteriosus closes and blood starts to flow from the left atria back to the heart, we're going to have really, really high pressures right here because it's so small and hypoplastic. That means blood's going to end up just shunting back over to the right side, going from the right atria to ventricle out to the lungs. Comes back to the left side, and the left side's hardly really even there because it's so hypoplastic. So it just shunts back over to the right side. And clearly, if we don't have that little escape route of that ductus arteriosus, we're going to stop getting enough blood out to the body. This baby's going to go into shock because they're not getting blood out to the body. So make sure, if you know this baby is coming, luckily we usually catch this on ultrasound nowadays, so we kind of are prepared. We want to be ready to start an IV and give that baby alprostadil. It's going to keep that ductus arteriosus open so they can get some blood out to their body. Clearly, they're still going to be really sick, so we need to make sure that we're prepared to care for them in the ICU. They actually get 3 stages of surgeries. It's not just like an easy fix like a Tet repair or the switch that we do in TGA. Instead, we have to do the Norwood pretty soon right after they're born. Then the Glenn, that happens a little bit later, on average around 2 months old. And then the Fontan, that happens even later, on average around 2 years old. And we can never make their heart perfect. We can never get normal blood flow going through the heart to the point where they don't really even need anything else. Down the road, it's likely that they could need a cardiac transplant. They might be listed for a ventricular assist device, depending on how well they're doing. But this is one of these ongoing conditions. Okay, let's look now at another question. What life-saving medication is indicated if an infant is ductal dependent? Think back to those meds. Got hypoplast, tricuspid atresia. What's that med I keep telling you? Yes, now you guys have got it. It's the alprostadil. Alprostadil keeps it open. Okay, let's look now at an infant born with TGA. What do you think he's going to look like? Which group was that in? Transposition of the great arteries. Is he going to be pink? Is he going to be blue? Ooh, okay, we got a mixed bag here. Transposition of the great arteries means that pulmonary artery and that aorta are switched. So the aorta, it's hooked up to the right side. What color blood does the right side have? That blue blood. So the aorta is going to be bringing deoxygenated blood out to the body, and we're going to have a blue baby with TGA. Nice. Really, really good, you guys. Okay. I only have one more defect to share with you. And it's not a mixed defect. It's something that we call obstructive. Okay. An obstructive defect is where there's some sort of force or, stricture stopping blood from getting out to the body. Okay. So this can technically happen a few ways. I'll show you. It can happen where one of our valves get stenotic, aortic stenosis, where that valve gets stiff and thickened, and it's really hard for blood to go out the aorta. We can also see it in the pulmonary valve. The pulmonary valve gets thick and stiffened, blood is obstructed, it's kind of hard for it to get out. But the one you're most likely to see questions about isn't where a valve gets stenotic. It's where we have a coarctation at a specific spot of the aorta. It happens right here. You see where we have that little stricture, that little narrowing. And when we have that narrowing, it's hard for blood to go past it. But because it's happening after these little blood vessels that you see at the top of the aorta, it leads to a really, really specific set of signs and symptoms. You see, these blood vessels, they bring blood to the upper half of the body, my face, my hands, all that. So they're getting lots of blood. But everything below that little stricture or kink, not so much, not getting a lot of blood. That means my legs, my feet, that part, not perfused well. So we look for that specific symptomology on all of our new babies to help us figure out if potentially they have this coarctation of the aorta going on. Lots of blood up top, not a lot of blood down below. That's what we're looking for. So up top, pulses are bounding, high blood pressure, they're warm, they're pink. Down below, it's the opposite. Weak, absent pulses, low BP, pale, cool, clammy. Okay? So, what are we going to do if there's a critical stenosis, a critical coarctation? We are going to have to open it up. Let's go back to the picture. Right here, we've got this stricture. We need to open it up. Okay, so they need a balloon valvuloplasty is the name of the procedure to kind of open that up. And then hopefully long term, it won't go back. There is a chance that this stricture can come back and they'll need another surgery in the long run. Okay, we're doing good. We're almost to time here, but we want to do one more question to determine our winner. So I'm going to ask you about that coarctation of the aorta, because I think that was the most important one from our obstructive. Get ready here and tell me which assessment findings would make you think that your client could have coarctation of the aorta. Okay, give you a good little bit of time here because you got to read through all these. Right. Coarctation, we got that stricture of the aorta. What assessment findings is that causing? Good. Of course, it's a select all that apply. You know you're going to see them. Yes, yes. Okay. Remember, this is for the winner. All right, here we go. Answers across the board. Let's see which ones are right. B, C, and E. These are the signs that tell us we have a lot of blood up top and not a lot of blood down below, which is exactly what's happening in a coarctation of the aorta. We get tons of blood up top, the aorta kinks off, and then down below, nothing else is happening. So up top, we would have bounding pulses. Radial pulses wouldn't be +1, they would be +3. And then those femoral pulses, they would be like +1. So that A, that's flip-flopped. Now B, where we have pale feet but warm hands, absolutely. What about blood pressures? Up top, brachial, hypertensive, lots of blood flowing up there. But down below, hypotensive. That's your popliteal blood pressure. That's on your calf. What about cap refills? A normal cap refill, less than 2 to 3 seconds, really brisk. So that's what I would see on my hands. On my feet, that's going to be sluggish. That's when I'm going to have that greater than 4-second capillary refill. Let's see who our winner is. All right, Liz, you hung on to it the whole class. That's amazing. Liz, you are the winner of 2 private tutoring sessions. Remember, one for you and one for your best nurse pal. So go ahead and shoot us a message. I'm going to go ahead and give everyone our email address in all of the chats. I'll say it out loud too. It is nclextutors@archerreview.com. So I'm going to put that in all of the chats right now. And Liz, you go ahead and let us know. And all the rest of you, if you happen to have questions that we maybe did not answer for you enough, or you want to purchase a product and you need a little bit of help sorting it out, that email address is open for everyone, okay? We always want to make sure we are answering your questions. And in that spirit, I'm going to go ahead and open up just a good old-fashioned Q&A session for about the next 5 minutes while we wrap things up. Let me scroll down here, get to our latest question. If you are still in Slido, this is what you should see now. If not, you can scan that QR code and I will answer any of your questions that you have right now. If there's something that wasn't quite clear or you want me to go over it again, pop it into this Q&A. All right, so it looks like the most recent question I have here is, when is the next session? So we do free webinars on Wednesdays. So every single Wednesday, they're usually about this time, but we try to mix it up so that everybody can attend. We are coming at you with a free webinar. They're going to be all sorts of different topics. So today was congenital heart defects. We might have one on study tips and tricks. We might have one on NGN questions, like how to do a bow tie or how to do a case study. They're all over the place. We try to really make sure to answer everything. So come join us every Wednesday. Now, I'm seeing a question in our Zoom chat asking if this session will be recorded. We don't have specifically like every single session recorded, but we have very high quality on-demand videos that cover all of these topics. So for those of you who told me you're already Archer subscribers, you've got the SurePass program, then you are good to go. You can go to your Archer Review student dashboard, watch your pediatric video, and go to the cardiac section. The cardiac section is going to have all of this information on demand, recorded, really well polished for you. And I saw somebody said, if we could, like, where would all these terms be? And that's exactly where they would be. If you need to go back and study atresia, stenosis, hypoplasia, they're all going to be in your pediatric video in the cardiac section. So you can make sure to review all of that as much as you need. Yes. Okay, let's see if we have any other questions. Pop them in Slido for me. Again, Liz, just shoot us an email over at nklextutors@archerview.com. We're going to set you up with your 2 free private tutoring sessions. If any of the rest of you need to book anything, if you need to get a private tutoring session, we can go ahead and put those links for you. Hopefully throughout you kind of got the info that you needed and whatnot. But as always, just send us a message if you need it. All right, I'm glad it was helpful, Joy. Really good. Well, I will stick around just in the chats for a sec. I'll go ahead and put the slide back up here. And if you guys need anything else from me, you just let me know. But I will see you next time back here for Archer Review's free webinar Wednesday. Have a great night, everyone.